Pregnancy quietly pushes the heart into one of the highest sustained workloads it will ever face. And most people don't realize this until something goes wrong. At the center of this workload is cardiac output. Cardiac output is the volume of blood the heart pumps every minute. And during pregnancy, cardiac output does not increase slightly, it increases dramatically. By mid-pregnancy, cardiac output can rise by as much as 30 to 50% above pre-pregnancy levels. This increase happens through two tightly coordinated mechanisms. First, heart rate increases. As pregnancy progresses, the maternal heart rate gradually rises, often by 10 to 20 beats per minute. Second, stroke volume increases. Because blood volume has expanded and venous return to the heart is higher, each heartbeat pumps more blood forward. When heart rate increases and stroke volume increases together, cardiac output rises significantly. This means that every single minute, the maternal heart is circulating far more blood than before pregnancy, continuously, to meet both maternal and fetal demands. This increase in cardiac output is not optional. It is essential for maintaining uteroplacental blood flow, supporting fetal oxygen delivery, and meeting the increased metabolic demands of pregnancy. Yet despite this increased cardiac workload, blood pressure often remains normal or even slightly reduced in early pregnancy. This is because systemic vascular resistance is low, blood vessels are dilated, resistance is reduced. So even though more blood is being pumped, it flows with less opposition. If this connection between cardiac output and vascular resistance is becoming clearer for you, pause here, save this video, and follow EliteMedicNexus, because this relationship explains almost every cardiovascular complication in pregnancy. As pregnancy advances into the third trimester, this balance begins to shift. Systemic vascular resistance may start to rise again. Blood pressure may return to pre-pregnancy levels or increase, but cardiac output remains elevated. This combination places significant stress on the heart and explains why late pregnancy is a vulnerable period, especially for women with underlying heart disease, anemia, hypertension, or volume overload. It also explains why symptoms such as palpitations, shortness of breath on exertion, and fatigue are common even in normal pregnancy. In most cases, the heart is not failing, it is adapting. However, when the heart cannot meet this increased demand, decompensation occurs. This is why some cardiac conditions first become symptomatic during pregnancy, even in women who were previously stable. From an exam and clinical perspective, timing matters. Cardiac output begins to rise early in pregnancy, peaks around mid-pregnancy, and remains elevated until delivery. Any condition that limits the heart's ability to increase output increases maternal risk. The key takeaway is simple but powerful. Pregnancy forces the heart to work harder, faster, and continuously for months. When adaptation is successful, pregnancy progresses safely. When adaptation fails, cardiovascular complications emerge. Follow EliteMedicNexus and stay with me, because in the next lesson, we'll see how labor and delivery push this cardiovascular system to its absolute limit.